Hello, I'm Dr. Mirvat Alasnag. I'm an interventional cardiologist at King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. I'm also an editor at the US Cardiology in Review and a member of the Society of Cardiovascular Angiography and Interventions Board of Trustees and the ACC Interventional Leadership Council. I'm here with Dr. Michael Mack, who is a cardiac surgeon and the chair of the cardiovascular service line at Baylor Scott and White Health and the president of the Baylor Scott and White Research Institute in Dallas, Texas. Also with us today is Dr. David Cohen. He is an interventional structural cardiologist at St. Francis Hospital in New York, and he also serves as the Director of Clinical and Outcomes Research at the Cardiovascular Research Foundation. We're here to discuss how guidelines are constructed and elaborated. Gentlemen, thank you for joining me today.
Thanks for having us, Mirvat.
There have been lots of discussions on the process that is undertaken to select and elaborate guidelines. I'd like us to address this today. And so to start off, Dr. Mack, how is the evidence base used as the foundation of guidelines that are generated?
Well, I think there's multiple answers to that, Mirvat. The first of all is that the guidelines are just that, guidelines. They aren't strict mandates, but they're meant to to provide guidelines to clinical practice and clinical judgment in practice. They are totally evidence-based, and what that means is they're based upon a broad and in-depth review of the evidence in the peer-reviewed published literature to inform clinical practice. For each guideline, for at least for the American guidelines, the ACC AHA guidelines, a joint committee of clinical practice guidelines appoints a panel of experts who are multi-specialty in various aspects of the disease for which the guidelines are being written. Then the peer-reviewed literature is reviewed for all publications relevant to the subject, including a number of relevant keywords to it. A guideline committee is convened based upon experts in the area representing multiple specialties. There are considerations made to multiple aspects of composing that committee, including demographics, diversity, relationship with industry, specialties. Once those are convened, the committee meets, and it's a very in-depth process looking at the previous guidelines, what need to be updated, what new evidence has been generated, and then what that level of evidence is that justifies a change to the guidelines or continuation of the same and previous recommendations.
Thank you. And that really takes me to the next question. Dr. Cohen, how can appropriate representation be guaranteed in such documents, particularly diversity of expertise and affiliations and so on?
Right. Thanks, Mirvat. That's a great question and a good follow-up to Mike's initial comments. Clearly, diversity in a variety of factors is critical these days when you're making something that is as political and potentially contentious and challenging as guidelines. And so I think that needs to be a strong consideration. There are many different ways that can be achieved right now. Most of the guidelines try to do that through the selection process of the members, which usually is directed by the chair and the co-chair of the guideline committees. But I think what's really important is you can imagine that there are many different domains on which one could try to achieve balance and representation. Could be gender, could be minority groups, could be different specialties, could be a geographic or even career stage. All of these things are very relevant when one is selecting a guideline committee. Obviously, with a unless you're going to have committees of 50 or 100 people, which are unworkable for a variety of other reasons, one may not be able to achieve ideal balance on all of those different factors. So to me, one of the keys is to have some guidance on really some parameters that we want to achieve when establishing these groups, something that comes from the leadership of this, the societies, or even from the membership. What do we value? What is the most important thing to balance? Should it be the specialty that the people are doing? What is the next most important? Because you're never going to have 50-50 on all different parameters. So we have to have some priorities and make sure that we achieve those. And then there can be other parameters that may be secondary, where there still is some interest in achieving diversity, but perhaps it's a little less mission critical. I think right now it's clear that we need to have absolutely need to have different specialties because they have different views of the patients. I think we ideally need to have different genders and racial diversity, and then everything else maybe is a little bit less, less mission critical. I think one of the interesting questions, which has come up in a lot of recent discussions, is what is the role of the patient? Should there be patients on the guideline committees? And I think that's a really interesting question. I haven't seen it yet, although I'm certain that there probably are some that I just don't know about that have had patient representatives. It's a very interesting topic of how do you integrate patients, who are obviously the goal of guidelines is to care for patients better. But how do we integrate them into the process?
Dr. Mack, you had a follow up on that?
Yeah, a couple comments. First of all, Dave, there was a patient representative involved with the recent 2020 valve guidelines. That was very helpful to have involved in the process. And then secondly, to assure that the diversity of opinion and that the evidence base is appropriate, all the guidelines, once they're written, undergo a peer review process. And there are two lead reviewers, one from ACC and one from AHA, and then multiple sub-reviewers to it. And one of the reasons for the delay or the time that it took to get the recent guidelines out is there were over 1,000 peer review comments to the valve guidelines, each of which had to be answered specifically. So again, there's a lot involved in making sausage. It's not all pretty, but it is onerous. It requires a lot of commitment, especially on the leaders of the guidelines.
Thanks for clarifying that, Mike. It is an enormous undertaking. That's clear.
It is, absolutely. And I think what probably makes it more difficult is we want to keep guidelines current and a reflection of the most recent evidence. So more contemporary living document. And it does take quite some time to elaborate a single guideline document. So how can we do that, Dr. Mack?
So the ACC-AHA Guidelines Committee updated the format, I believe, starting in 2016. They went to something called knowledge chunk format. Previously, when you had guidelines written, the whole guideline had to be updated. It then progressed to what are called focused updates. So for instance, if we take valve guidelines again, the last full guideline was in 2014. There was a focused update in 2017. This time, the 2020 guidelines, it's in this knowledge chunk format to create exactly what you're alluding to, which is a living document. So if there's new, clear evidence that mandates a change in the recommendation, that is constantly monitored and can be updated on an as-needed basis based upon the review and opinion of the guidelines committee. Now, this is, I think, the third guideline that this is being incorporated into, and whether it really works as well and as expeditiously as designed remains to be seen. But I think everybody is dissatisfied with how quickly the guidelines become outdated.
Yeah, absolutely. And Dr. Cohen, I'll go to you now. Dr. Mack just explained to us the process for the American guidelines. Do you, as somebody who abides by guidelines and follows guidelines and believes in evidence base, do you find a difference between the European and the American guidelines?
It's a really great question. So I can't speak with any expertise on how the European guidelines are created differently than the U.S. guidelines, having never served on a European guideline committee. But I can speak to the to what you can see when you look at the guidelines. And I'd say traditionally they actually have been moderately different between the U.S. and the European guidelines. I think they're starting to come a little bit more together, but I would say traditionally the U.S. guidelines, in my view, a lot of them were, I would say, very academic in the sense that they were extraordinarily sort of orthodox in the interpretation of the literature and somewhat reluctant, I would say, to go out on a limb where the literature was unclear. That's my perception as a user of the guidelines. Whereas I think historically the European guidelines have had a little bit more of a pragmatic approach that said, we want to, really impact practice, and a lot of the areas where there's uncertainty is the place where people need the most help. I don't need help figuring out that patients with coronary artery disease need a statin, or a patient with severe symptomatic aortic stenosis needs their valve replaced in one way or another. What I need help with is, how do I manage the patient with asymptomatic severe aortic stenosis, or the patient who is failed a statin, is not sufficiently well controlled. The areas where the evidence maybe not as clear. And I think the Europeans have traditionally been a little bit more willing to use even expert opinion as the basis for relatively strong prescriptive guidelines. I do think those are coming closer together. I think the valve guidelines that just came out are a great example where I see a tremendous emphasis on being practical and useful to the clinician. I would say one other area that does differ is an area that's of interest in particular to me along the lines of my research, which is that the US guidelines traditionally have really stayed away from this knotty issue of cost. There was, for a long time, you couldn't talk about the cost at all in the guidelines. It was as though we were pretending it didn't exist. Now the U.S. guidelines do have, a provision where cost can be an extra component. It's a value component that's built into them, although they're not in the primary clinical guidelines. So it's coming along. But I think, again, the Europeans, perhaps because they have more of a sort of public health and a publicly funded healthcare system there, have been more cognizant of cost in some of their recommendations, which in the current era does seem relevant. And I think that it is something where the U.S. guidelines need to continue to push.
Thank you. You do bring up important points that, the most obvious recommendations, we don't really need guidance. We need it for the more difficult questions. And interestingly, yes, the lipid management guidelines for the first time addressed cost of PCSK9 inhibitors and so on. So perhaps that is a change that's coming. Dr. Mack, as we venture into topics that are more difficult and the evidence is not necessarily level 1A, should there be an independent analytic center that looks at the evidence in an unbiased manner and informs the guideline writers of their analysis for this evidence? What are your thoughts?
I love that suggestion. I think we all try to step back and be objective, but we're all a product of our own experience, and we bring biases to the table, no matter how objective we try to be. Also, none of us, that are in clinical practice, or very few of us, are experts in statistical analyses. So the idea that an independent analytic center that just looks at the data without a background in the subject matter that's under consideration, I think brings a lot to the table. I had experience a number of years ago with the International Society for Minimally Invasive Cardiac Surgery, which does just that. They have an independent analytic center that analyzes all the data, including the randomized trials, presents forest plots and a very detailed and understandable analysis of all the data, and gives you guidelines for the guidelines as to what you can say regarding what level of evidence is met or not met based on it. So yes, I love the idea and I'm a strong proponent of it.
Thank you. That was certainly very enlightening. So, just before we close off, I'll go to Dr. Cohen one more time. What topics so far in interventional cardiology, and I know I'm biased, I am an interventional cardiologist, but which of the topics do you think warrant a statement and haven't been addressed by guidelines so far?
It was a good question, and I'm glad you asked it before we got on this call, on this program together, because it's one, there's so many guidelines already that it's, I had to struggle a little bit to think of areas where I thought, well, maybe it's time for a guideline. And I'll raise two, and then I'll tell you why maybe the time still isn't right. One is the whole area that's really burgeoning now of coronary microvascular disease, MINOCA. All of this doesn't really have a guideline. There are parts of the AMI guidelines that deal with it. And certainly there should be parts in the chronic stable ischemic heart disease, but maybe they need its own special guideline because it is a very specialized area. The second area is one that's even closer to an interventionalist's sweet spot, which is the whole area of cardiogenic shock, AMI, and support devices, which again, I think these are areas where we need guidelines. The problem, and the reason why we don't have guidelines, really strong guidelines in these areas, is because we don't have evidence in these areas. And so I think it is very difficult to make much of a guideline when you don't have much evidence for it. So I think these are areas that we need to sort of be aware of, kind of pay attention to, and see when the evidence catches up with the need. As we've said, I guess maybe that's going to be the theme here, is the areas where we need the most guidelines are always the ones where we have the least evidence. Because those are the ones where there's so much uncertainty, so much practice variation, and they usually point to areas that need a lot better studies for that. So those are a couple that are on my mind. I'm sure there are others that I've forgotten, but I think one of the things cardiology is really good at is guidelines. We make a lot of them, so there aren't a huge number of holes, thankfully.
Wonderful, Dr. Mack. Do you think there's anything missing in the surgical guidelines?
So. I agree totally with what Dave said. And when you don't have the evidence sufficient to support a guideline, expert consensus statements are an alternative that helps guide practice that way. I would say that one of the other areas, in addition to what Dave mentioned, is the use of ECMO. Which has been burgeoning the last couple of years and really exploded with the COVID experience. And there is a fair amount of evidence being generated about the use of COVID, both for COVID and non-COVID uses, pulmonary and cardiogenic shock uses, and especially as it intersects with some of the percutaneous methods of supporting cardiogenic shock. So that would be the other area I see.
Well, thank you both for taking the time to be with us this afternoon, and hopefully we'll see you again with another episode with Radcliffe Cardiology. Thank you, everyone.